All right, hello everybody. Welcome to week 8. Hope everybody is having a good week so far. It's Wednesday. Good week. All right, week so far. You okay, Jessica?
It's too cold.
Is it? Okay, I won't tell you it's 78 degrees here then, okay? All right, so we are still missing a couple. All right, Mariah, Jacqueline, are you there?
I think I'm in here twice. I need you to kick
Oh,
me.
I see. Yeah, you are on there twice. I see you now. Okay. You got your eclipse behind you on one.
Hey, Miss Jennifer, you heard about Quana?
No.
Okay, I sent you a private message.
Okay. All right. Danae, are you there? There you are. All right. Yeah. I can't believe that people are still getting snow. It's like, okay, we're almost in April. We can we can stop with that now. Um, Thanks to that good old groundhog, right? Decided he wanted to um all right. So again, welcome to week 8. We're on the downhill now. So you have exam 3 coming up, and then your HESI, and just a couple more assignments. So make sure that you get those turned in. Keep up the really good work that you're doing, um, and everything will be great. All right. All right. So today, it isn't nighttime yet. Um, all right. Okay. So tonight's focus, or I don't know why I keep saying tonight. Today's focus, we're gonna get there. It's afternoon, it's not night. We are going to talk about end of life care. So for your concepts book, it's chapter 51. And then in your basic geriatric nursing book, it's going to be chapter 15. Um, so I will share my screen. I did post the PowerPoints for you. Um, so you do have those. Um, all right. So end of life care. So the focus of the end of life care shifts from those invasive life-saving procedures, right, to comfort measures and control of symptoms. And so insurance companies and hospice agencies define the end of life stage as 6 months before death. But obviously it's difficult to predict that. Generally speaking, you have to have a prognosis of less than 6 or 6 months or less, to qualify for hospice. And we know that, not everybody is going to die within that 6 months, and we can be on hospice for longer periods of time. So nursing interventions for the physical symptoms, managing the pain, the shortness of breath, the nausea, the vomiting, appetite loss, incontinence, and of course, skin breakdown, psychological and spiritual symptoms, supporting patients as well as their families in times of anxiety, fear, depression, of course, spiritual distress. And we've talked about spirituality as well, and the effect that can have on the person. Spiritual distress can occur if the patient's unable to accept that their life is coming to an end, or if they feel disconnected from a divine being or religious community. Caregiver support. right? That's just as important as providing care to the client themselves. So we'll educate the families and the caregivers about the dying process, kind of some things to expect. The caregivers also are going to experience stress as well as a negative impact, right, on their physical health as possible as well. There is family bereavement support that is offered through hospice services too. Um, so there's an increased risk of illness and death among people who have lost a loved one, right? So that bereavement is important so that we can help them to maintain their physical as well as their emotional life, or emotional health and grief. I mean, grief is individualized. Everybody experiences grief. Um, in a different way. But it can be physical, it can be psychological, cognitive, spiritual. Again, it's different from one person to another. Everyone experiences grief in their own way. Complicated grief, on the other hand, that occurs when a person is unable to process grief and move forward after an extended period of mourning. So again, the bereavement services are really important. Some hospice agencies are really good with offering their bereavement services. Some need a little bit of help with that. So again, it's going to be chapter 51 in your concepts book, and then chapter 15 in your basic geriatric nursing text. So you've heard of palliative care before, right? Um, and so palliative care is a holistic approach, right? It addresses the physical, the psychological, the emotional, the social, the cultural, the spiritual needs of patients as well as their families. Um, it also focuses on anticipation, prevention, and treatment of suffering in patients with complex medical conditions or even life-limiting illnesses. So it's a holistic approach. We're trying to address all of the symptoms, the things that they are going through during this period of time. And palliative care provides care through the continuum of illness. Okay. So one of the big differences between palliative care and hospice care is anybody can receive palliative care. All right. So what are some examples of palliative care?
Pain management,
Okay. Pain management. What else?
Hygiene,
Okay. Hygiene.
just keeping them comfortable.
Okay. So palliative care, yeah, it's keeping them comfortable. It's giving them things um to help them. So palliative care can be something as simple as even giving fluids to somebody who is extremely, that has nausea and vomiting and diarrhea, right? That is extremely dehydrated, right? So it's just it's care to help keep them comfortable. And so it is a little bit different than hospice care. We can use, with palliative care, they can still receive like their life-saving treatments, their chemo, radiation, and other life-saving treatments. Whereas with hospice, right, generally those life-saving treatments have been discontinued. Um, so again, we can use palliative care throughout the whole process, but we can use palliative care in any, for anybody, not just those that are at end of life. Um, and so it's, there's lots of people that are involved, the nurses, the doctors, chaplain services are really effective as well, social workers, case managers, right? There may also be volunteers, home health aides, CNAs, right, a slew of people that can be involved in that person's care. And palliative care can be offered much like hospice care can be it can be offered anywhere. In home health, the hospital, long-term care, rehab, outpatient clinics as well. And again, like I said, palliative care can take place at the same time as curative treatments. Um, unlike with hospice, right? That is when we usually stop those treatments. And I think I was telling you, um, so one of the big things that I noticed when I came down here is we have hospice patients that are still full codes. Which did I tell you guys that? Or it might have been another class. Um, so yes. Um, so that was a big shock for me. And I've worked with hospice patients, throughout my career. And they've all been DNRs, right? Because the whole premise behind hospice care, right, is death with dignity and helping them through the dying process. Um, and when I came down here, um, I have I have a couple hospice patients that are full codes, and I don't quite understand it. Um, but yes, so terminal illnesses and are still full codes. So if I have to, if they do pass, then I do have to still perform CPR, send them to the hospital, do all of those wonderful things. Which I not that I mind saving a person's life, but I just, to me, like the concept, right? I couldn't put the concepts together, right? Because like I said, when you think of hospice, right, you think of death with dignity and helping them through the dying process. And to have, clients that are on hospice care that are still full codes, right? It was just a totally different thought process for me. And so I just thought that was interesting. Has anybody ever come across something like that before? No. All right. So we look at the needs of a dying patient. We can use Maslow's hierarchy of needs, right? Human needs at the end of life are, they follow the same universal patterns that of anybody, that is even, just anybody. And so what do when we look at people who are dying, and look at the physiological needs of patients on Maslow, according to Maslow's, right? Those basic physiological needs: air, water, food, shelter, sleep, clothing, reproduction, right? Those are every human's basic needs. So, taking just the basic needs into consideration, think of a hospice patient, right? What does the dying person need, right? Biggest thing is to be free or relief from those physical symptoms, right? Not every dying process involves pain, all right? But we want to try to relieve any of their physical symptoms, whether it's, whether it's pain, whether it's nausea, whether it's vomiting, excessive secretions, any of those things. Um, and to have relief from pain for those other patients. Those safety security needs, right? The next level on Maslow's is your personal security, the employment, resources, health, property, things like that. Um, with this, right? I don't know, has anybody ever worked with a hospice patient before?
I have.
Okay. Um, there's a lot of different emotions, right, that
Mhm.
go through patients' minds. Jacqueline, you brought up a good point. I'm sorry. So Jacqueline just wrote in here that a lot of them are too frail and can't physically survive a code, right? That's the scary part. Absolutely, 100%. Especially when you look at like some of your later stage cancer patients, right? They're very thin, they're very frail. Um, and performing CPR people don't understand what happens when you perform CPR, right? They don't want to die. And it's a scary experience to have to make that decision. Um, but yes, it is a lot of that. I remember it just brings me back to the first time that I had to do CPR. Um, and I will tell you, she was a very large woman. I think she was closer to like 400 or 500 pounds. Um, and still, when I did those, every time, that first few compressions, I felt every single one of her ribs just crack underneath the pressure of CPR. And so, even if she did not survive, um, but you think about that, the goal of premise or the premise of hospice, right, is one of the biggest things is pain relief. And so if you have a hospice and hospice patient, you code that patient, if I break all your ribs, imagine the pain that that is going to cause, and not only the pain, but the potential damage, right, that can result between, potentially, muscle damage and, potentially puncturing lungs and other things. So, yeah, a lot of them are very frail. And I need to think about it, and it does scare me to have to do CPR on some of these clients. Um, yeah, I couldn't, yeah, I don't want to think about that. Hopefully, knock on wood, I don't have to. Um, but with safety and security, they need to be able to express their hidden fears, right? They need to be able to trust the people, right, that are taking care of them, to feel that they are being told the truth, to be secure, safe, right, in their environment, with love and belonging. This is another one too, be able to talk, to be, listened to, to still be loved, to share love, to love their families, right? To be with someone they love when they die. And so, working in long-term care, unfortunately have lost quite a few patients, right? Just because of the environment that I work in, because people get older and whether they're hospice or not, right? Eventually they will pass. Um, I was always the one who, like, I could never have somebody die alone. Like, I always felt like that was just I don't know how to explain it. But I
Agree.
never wanted someone to die alone. And so if I could be there, whether it's just sitting in the room with them, holding their hands, whatever it is, right? Nobody wants to die alone, right? It has to be unfortunately, I don't know, but, um, okay, yeah. So, um, it is something. I took care of my mom. We put my mom in hospice. Um, and she didn't make it 6 months. I think she made it 3 months. But one of my mom's biggest wishes, when she had always told us that she wanted to die at home. She did not want to die in the hospital, in a facility, or somewhere along those lines. So we were able, to keep her at home, and take care of her at home until she passed. And when she did pass, we were all there. So she was surrounded by, her kids and most of her grandkids. So we were, all able to be there and, provide that sense of comfort for her. Um, but again, they it is a process, and it's not just for the person that is terminal, but it is for the family as well, right? Because they are going to go through those stages of grief. But we do have to make sure that we are providing that really good comfort care. So love and belonging, of course, we want to assess their needs and wants for end of life. And there's a variety of different interventions that can be provided. the biggest thing is to maintain dignity and respect with those dying patients. Giving them as much control over their end of life decisions, as much as possible. Um, sorry, and allow them to come to terms with their death, especially if it's inevitable. And they really have to be able to come to terms with that. And like I said earlier, relief from symptoms is one of the biggest things that we do have to look at, is making sure that they're comfortable. Nobody wants to be uncomfortable, right? Um, whatever comfort that we can provide to them. So, how do we know what your wishes are? So, and this is something that everybody should be encouraged to do. Um, and that is your advanced directives. And I don't know, a lot of you are very young and probably haven't even thought about these things. Um, but I will tell you that advanced directives are very important. Um, so like I said, there's a lot of different treatment options that are available to someone in that end of life period. Um, and, deciding what to have, what not to have, what to do and what not to do, right? That can be a little overwhelming. Um, so many older people say that they don't fear death as much as they fear how they will die, right? And one of the biggest fears that people have is pain. So one thing that you can do while you're young, or relatively young, is set up an advanced directive. And so advanced directives basically outline the care that you want to receive should you ever be in a situation where you can no longer make those decisions, right? So, obviously, it could be that um, you want CPR, you don't want CPR, you want IV fluids, oxygen, tube, feedings, whatever it is. That you're making plans about your wishes while you are still healthy. Um, a medical power of attorney, on the other hand, is something a little bit different. A medical power of attorney assigns somebody to make those decisions for you should you not be able to make them for yourself. Okay, so, you know, someone, like maybe it's your child or your spouse or, somebody that is very well trusted by you, that should you be not able to make medical decisions for yourself, that you would appoint someone to make those decisions for you. Biggest thing with that, right, is you have to make sure that you trust that person wholeheartedly, and that you trust that they will act in your best interest, right? To make sure that you are getting the care that you request. Um, and when it comes, if and when it comes down to that. Um, but again, you can make those decisions now. Go ahead.
So I have a question about that. With
Hmm.
you said it's called a medical power of attorney.
Hmm.
So with that family member that you trust or whatnot, and you have an advance directive, can they? Let's say that person just isn't ready for you to go. Can they challenge your advance directive or no?
They can.
That's what I wanted to. Yeah. Okay. So in a situation like that, how would you, as the nurse, not necessarily handle that situation? Because I know that's more of like a legal thing. How would that play out? I guess I'm not sure. I'm trying to ask this.
So it's about being a patient advocate,
Mm-hmm.
right? Doing what's best for your patient and providing education to the family. a
Right.
lot of time, and you can provide a lot of education to, patients and their families, especially when they're making decisions that they're not prepared to make. And a lot of it's advocating for your patients. And so just like we were talking about doing CPR on some of these very frail and weak, right? Patients that are, towards the end of life, it's education. So I'm going to give an example. So, and I'm not going to use my example because I will be here crying, but um, I had a patient. This woman, I love this woman. I can't tell you how much I love this woman. She was the sweetest little thing in the whole world. She was a dialysis patient, all right, very thin, very frail, couldn't walk anymore. And went to dialysis 3 times a week. And I would tell you, probably soaking wet, she was probably about 120 pounds, like very thin. Okay. So I remember her because she started off on our skilled care unit and she was NPO, right? She had a tube feeding as well. But she would always ask for ice, always asking for ice. And so no matter how much we did oral care on her, her mouth was just horribly dry, to the point where like even her tongue would be red and swollen and just horrible. So the doctor said that we could do ice chips. So I would go in there with the ice and I would just lay them on her tongue and she would just leave her mouth open and let the ice just like, melt on her tongue. So we became very attached. Um, so long story short, when she transferred to long-term care, she was still on dialysis and still receiving her tube feedings and all of that. And she came back from dialysis one day and she was like, I don't want to do this anymore. And we were like, what? What do you mean you don't want to do it anymore? She says, I'm done. So, dialysis is, right? It's removing all of the extra fluid from the body because the patient's kidneys don't work. All right. Some dialysis patients still urinate a little bit, others don't urinate at all. So she did not urinate at all. And so when she decided to stop dialysis, I had never seen anything before like this in my life, and I had no idea what it was going to happen. But basically, she went from like 125 pounds to like 150 pounds just from the retained fluid from not going to dialysis. Her lungs filled up, and it was literally like watching a drowning person and nothing that you could do for it. So, why I bring this up, I don't remember who I was talking to. Okay. Um, it was I want to say it was a coworker, somebody I knew. It wasn't like in a class or anything like that. And I don't remember who it was. And we were talking about this process. And I remember thinking to myself, like, why we had started the conversation. But I just remember saying, because I felt horrible, like there was nothing I could do for her, nothing to ease her breathing, right? No matter how much oxygen you gave, her lungs were just filling up with fluid. Um, and the person that I was talking to, and I didn't know, she looked at me, she goes, I wish somebody had told me that. And I said, what do you mean? And she said her mom had gone through that too. Her mom was on dialysis and she had decided to stop her dialysis, but her, as her daughter, she had no idea what the process was going to be like. And of course, watching her mom suffer was horrible for her. She said, but nobody had given us that information. Nobody had told us that that was what was going to happen. And so that's why I say education and advocacy is super important, right? These are the patient's wishes. Now she didn't go against her mom's wishes, right? She went with her mom's wishes. Um, and, they kept her, just like we kept my client, my patient as comfortable as possible, right? Towards that, towards the end of life. Um, but that's the thing, it's education, right? What is going to happen? what happens when you have to do CPR on on 98-year-old grandma, right? Who, is just, whether they're in hospice care or not, right? Letting them know this is what we're going to do, right? We're going to do CPR. Ribs are going to be cracked. Like there's no, and obviously it's going to be a little bit more tactful, right? But you really want to tell them what's going to happen. Um, and I know that people, just like we have situations too where patients really, need to be in hospice care, right? Need to be DNRs, but the parents or the family members aren't willing, right, to make that decision. And that's the best that you can do is advocate for your patient education, educate the family. Um, because what's not that we know what's best for the clients, we know what can happen, right? We know what the end results are. um and yeah, you're going to come across that a lot, believe it or not, unfortunately, where family members just are, they have a hard time. They're not ready to give up. They're not ready to let their loved one pass. But I think a lot of it too is just lack of knowledge, right? They don't know what CPR really entails. And then think about it too, okay, say we do CPR and we get a heart, we get the heart pumping again. Um, they may end up being intubated, having to get, so there's a lot of other, things that could potentially go wrong. Um, but really that's what it is. It's as much education. You're going to come across that. I've come across that. And I would just sit here and pray, like, I really hope I don't have to do CPR on this patient because I know that they probably won't survive the CPR. But that's what it is. It's really just being an advocate for your patient and just lots of education for the family. Um, Sometimes you can make a difference in when, in that effect, but sometimes you can't. You know, I don't want to, our thing is too, is, especially because I love my old people. I don't want them to go through the undue and the unnecessary pain and suffering that would be caused by performing CPR, especially when they're more frail and weak, just because, they may not even survive the CPR. And then it's almost like you're torturing them is how I feel sometimes. Not that I wouldn't do it. They request me to do CPR. I'm going to do CPR, right? Because I mean, that's our job, but just knowing the damage sometimes can be very overwhelming.
Okay, thank you.
Yep. All right. So, case study, Mr. Bill. So you're a nurse in a healthcare agency that provides palliative care and hospice. Your new patient, Bill, is a 68-year-old man who had a stroke 3 weeks ago. The stroke seemed to hit him out of nowhere. Bill is married with grown children. He had no advanced directive at the time of the stroke because he had no prior health concerns. Bill is still capable of making decisions and expressing his wishes, but he needs help regaining his quality of life. So, what level of care are we going to suggest for Bill? Hospice or palliative care? Palliative care, absolutely. Um, so what interventions can help him optimize his quality of life, right? Doesn't really say what he's lacking, but what could we do to help? Just think of anybody that's had a stroke. What are some things that we can do to help somebody regain quality of life?
Probably PT.
Okay, PT.
I was gonna say just get them rehabilitated, work on their strength and gait.
Yep. So PT, OT. If he's still capable of making decisions and expressing his wishes, probably doesn't need speech therapy, right? But definitely getting him some PT and OT, right? To gain, try to maximize his potential, right? Get back as much or get him, as close to his previous level of functioning as possible. And if he is still capable of making decisions, right, then we would want to encourage him, right, to make that, set up those advanced directives, right, now while he's still able to make those decisions. Then we have Helen. Helen is, so you're a nurse at a I'm sorry, you're a nurse at a home hospice agency. You're on duty when you get a call from the daughter of your 88-year-old patient, Helen. Helen was admitted to home hospice 2 months ago with heart failure. She's declined rapidly in the past few days. Her daughter says that Helen's breathing is shallow and irregular. She has stopped talking, but she sometimes moans. Her Foley catheter bag has been empty since yesterday, and then she asks you if her mother is about to die. The mother is about to die. Um, so, anybody know what are some of the um, signs that the daughter should look for to tell her if her mom is acutely dying?
Seeing passed away family members.
Okay, hallucinations is part of that. Yep.
Modeling at the feet.
Modeling at the feet, the knees as well. Okay.
You hear that death rattle when they're breathing.
Oh, yes, the death rattle. Those are your Cheyne-Stokes respirations. Yep. What else? Anybody?
When they have pets too, I don't know if it's weird, but it seems like the pets start clinging to them when they be knowing that it's almost that time. I
Yeah,
had a patient
they.
like that. The cat just stayed in the bed with her.
Mm-hmm. I've heard that. Do you know I'm trying to make a little bit of light of the situation, and I know it's hard, but I was reading, this was a long time ago. There was a cat in a long-term care facility that would go into the long-term care facility and it's like the cat knew that somebody was getting ready to pass, and she would always go into that room. Right. So animals do I feel like they have that sense. Um, but yes. Um, Oliguria, or the lack of urine output, is very common, right? Um,
What about the respiration change?
yep, the respiratory system changes. The respirations are short and shallow. They may be rapid as well. It really just depends. Um, but they also, skin breakdown is a huge potential issue. Um, Sensory changes. What's the last sense to go?
Your
They're
hearing.
very
The hearing, right? So regardless of your client, we always talk to our clients, right? Whether they're alert and oriented, or almost comatose, right? Or unresponsive. We always talk to our patients, let them know that we're there, let them know, what we're doing. We don't, ever just go in and start doing things just because they're not responsive. They get, they're going to start sleeping a lot more. The hallucinations. So one of the hardest things I will tell you is, and I know other people have may have worked with hospice with family members before. The week before my mom passed, my family and I forget where we had gone. We had gone shopping. We had gone to like the outlet malls or something, and we were driving home. And my mom called me, and she was telling me, she was like, I just talked to your dad, and he wanted me to let you know that he loved you, and he's sorry that he missed you growing up and all of this stuff. And I was like, I started crying, because my dad died when I was 7. And so, they start to have those hallucinations. They start to see things. They may start to like even, grab at things. Um,
But are they really hallucinations though? That's the question.
yeah. for us, right? Because we can't see what they're seeing, right? They would be considered hallucinations. Um, but yeah, they are seeing what they are seeing. Um, but yeah, so lots of different changes can occur in that end of life. The biggest thing, right, is to make sure that we, are keeping them as comfortable as possible. Um, she's sometimes moaning. So moaning could be, it could be from pain, it could be just respiratory changes. So, what do you think are some things that we can do to manage those symptoms?
Again, just keeping her comfortable. Morphine.
Right,
I know they do dilaudid, so just whatever it is to keep them comfortable. Like you said, repositioning her, making sure she's in a comfortable position where she's not like too crouched,
right,
but she's in a position where even though she's not breathing 100%, she's still able to breathe.
right. So we're still going to do the turning and repositioning, right? Especially because we don't want skin breakdown to occur. Um, Oxygen, right, may be necessary. Morphine, Ativan. If she has excessive secretions, we can do something like atropine, which is an anticholinergic, will help to dry up those secretions, right? So, if they're having difficulty swallowing, so the saliva is not pooling and increasing the risk for aspiration. Um, if her Foley bag has been empty for the last day, right, we know that that's just showing now that our systems are breaking down, right? Like our organ systems are starting to shut down. So good job. All right, let's go back to, we're going to talk more about palliative care. We'll still talk about some of the other stuff too, but so palliative care, like I said, this is symptom management, right? So this is pain. Um, like I said, it could be giving IV fluids, it could be giving oxygen, tube feedings, or even the TPN, right? It's focusing on symptom management. And does not mean with palliative care that they have to stop saying, that they have to stop the life-saving treatments. They can continue with the life-saving treatments. We're just trying to focus on those symptoms. It doesn't hasten or prolong death, right? We're just providing that symptomatic relief. And with palliative care, just like with anything, they can, decline procedures. If they decide that if their heart stops beating, if they stop breathing, right, they may not want CPR. They may not want to be intubated and mechanically ventilated. They may not want tube feeding, right? But that is their choice. Um, so just I'll make this a little bigger so I can see it too. So again, here is just some other, some differences between palliative care and hospice care. So palliative services are paid by the insurance as well as the client themselves. It's available at any stage of the disease from the beginning to the end. It can be offered at the same time as curative treatments are. Palliative care typically happens in the hospital, but we can offer palliative care in other settings as well. Hospice services are paid for Medicare or paid by Medicare, Medicaid, and insurance. Generally speaking, the prognosis is 6 months or less. And it excludes curative treatments, right? So generally, if somebody is going on hospice, they're going to stop the chemo, the radiation, any of those other, potentially curative treatments. Now, with that being said, I do want to highlight something here. If you have a hospice patient that gets strep throat or gets pneumonia or gets a urinary tract infection, that doesn't mean we don't treat those. We still absolutely treat those. Okay. We are just not providing the curative treatment for whatever disease process that is the cause of them. So if it's cancer, like I was telling about my patient who, decided to stop her dialysis, we're not going to stop treating them. We're just not providing those curative treatments. Okay. But if they get an infection, they have diabetes, we're still going to give them their insulin, right? We're not treating them, however I can say that. So, doesn't mean that we're not, like I said, they have a UTI. We're going to treat that with antibiotics. And hospice services can be provided wherever the patient calls home. So we can do it in hospitals, we can do it in long-term care settings, in skilled care, we can do it at home. Some of your hospice agencies also have hospice homes. All right, one of the weird things down here too, I know, it's been a little bit of a culture shock. There's actually, I don't know which one it is, but one of the hospice services actually rents out hotel rooms. And so they will provide care for the hospice patient in the hotel room versus home. So if, they don't want to die in their home, whatever the reason is, or if they don't have somewhere else to go, they will be in a hotel room. So I just don't want to go to that hotel. I believe in ghosts, okay?
Ms. Martinez, if I may ask a question, this might be a little off. When you have like a power of attorney or something, when you die, that dies with you, correct?
So for the medical power of attorney,
Yes.
yes. Um, so for medical power of attorney, yes. But then there's other types of power of attorneys that can stay in effect even after death.
Mhm.
So like for when you think of like um executorship, right? So let's say I make my son the executor of my will. Once I pass, he will still be able to act in my behalf after I die because I've given him that authority. So it just depends.
And like if you have like medical bills and stuff like that, does that die with you, or if you have a power of attorney that goes to them, that's not their bill?
Yeah. Usually what ends up happening is they'll be covered, they're part of the estate. Okay, so you own a home, you own a car, whatever it is, and you pass away and those assets get liquidated, right? You sell the home, you get rid of the car, and whatever money is owed for like medical bills is taken from the estate before like
Question,
the
Mrs.
family gets it.
Martinez. I see it says prognosis 6 months or less, but yet the facility I work at, I got like two patients who've been on hospice damn near 2+ years,
Yeah,
Mhm.
almost
because
3 years.
they come
How
and
does
read.
that work? What do they do? Like refile for hospice? How does that work?
So the prognosis, yes, technically the prognosis is supposed to be 6 months or less. They have to have a terminal disease.
Okay.
Um, but that doesn't mean that you're going to die within 6 months.
Yes. Now, can you
So
get hospice because of aging?
not just, how do I explain this? Um, when they start to decline significantly, then yes. Like I've seen hospice for your all like Alzheimer's and dementia patients, especially in the like later stages of dementia and Alzheimer's. Um, yes, yes,
Okay,
yes. Just basic to answer your question, yeah.
cool.
Um, yes, they do offer extra benefits and supplies. Thank you, Jacqueline. Yes. So yeah, they offer extra supplies, especially in skilled and long-term care facilities, which I always thought that was really kind of interesting. But so let's say you have a long-term care patient who, is really starting to decline, and the family has decided that they want to put her in hospice services. Okay. You're in a long-term care facility, right? They have they have beds, they have oxygen, they have all the things, right, to take care of the clients. But hospice will bring their own equipment in. They'll bring their own bed, they'll bring their own air mattresses, they'll bring their own suction equipment, oxygen equipment, wound care equipment.
And they take it right back.
I'm sorry?
And they take it back when the person passes.
Right. And then once the person passes, they come and they take all their equipment and clean it and recycle it for the next client. Go ahead,
I have a
Mike.
question.
Uh-huh.
Do they have hospice homes? You know how they have the rehab homes. Do they have hospice homes? Because, like you said, a lot of people don't like to die in their house.
Mm-hmm. Some
And
do
I don't
have
think
hospice homes.
they do.
Mm-hmm. Yeah.
I don't know how familiar you are with like Wilkes-Barre area, but there's a hospice right over there, Allied in Wilkes-Barre. Can't hear
muted,
you.
Anisha. You're
Oh,
muted.
sorry. No, not that type. That's still like a rehab. I mean, like something that's more of a home setting.
Like they going to a spot to die?
Yes.
Yeah, no, that's what this is. That's exactly what it is. It's literally if you have, and for this one, if you have less than 72 hours, they send you there. But
it looks like a
it's like,
nursing home.
oh, mm, not really. It's more like a hotel. It looks more like a hotel.
Oh, so I'm talking
Like
about an actual hospice home. Like you have group
oh,
homes. That's a home.
Well, she's saying, do
okay.
they have hospice facilities, just hospice patients? They just waiting there to die. That's what she's saying.
Yes. There are specific some organizations or some of your hospice companies, I guess, I don't know how to say it. They do have specific hospice homes that the patient can stay in. It just depends. Not all of them do, and that's why I was saying like one of the hospice companies here actually rents hotel rooms so that if the client doesn't want to stay at home to pass or be in the hospital, whatever, they can stay in the hotel and get
Yeah,
the hospice services.
that's like the one I was explaining to her. My uncle that passed away in December, we had him there, but you have like your own personal room. It's like a actual. It's like an actual hotel. You have your refrigerator there. You have your stove. You have like everything. It's literally set up as it literally looks like a home, just with different rooms. A different patient is in there, but they're all comfort care patients. So they're not like machines or anything of that sort in there.
Mm-hmm. Yeah. So they try to make it as homely and as comfortable as possible for the clients. But yeah, hospice can be anywhere. And that is, one of the nice things about it is it can be offered in a variety of different ways, in different areas. Both of them, they provide comfort care to reduce, reduction of stress, offer complex symptom relief, as well as providing for physical and psychosocial relief. I don't know why my slide doesn't want to move. So we'll go back to hospice care. So the focus of hospice is to provide comfort and support for emotional as well as spiritual needs of patients and their families. Again, it's usually, they're terminal, they have a terminal illness, generally speaking, a prognosis of 6 months. It doesn't like us, like Joseph was saying, they don't have to die within 6 months. Okay. Their prognosis has to be, has to have a terminal diagnosis. Again, it's nurses, nurse aides, home health aides, there's chaplains, there's social workers, there's care managers. Um, I'm trying to think, sometimes there's volunteers that will also help with hospice. It depends on the organization, the company that is there. Um, and so ethical dilemmas with hospice patients. So I shared mine, right, with the CPR. But your ethical dilemmas, and we talked about this, the medical power of attorney or somebody not wanting to follow through with the wishes of, the patient themselves. So those ethical dilemmas can occur when the value systems of the patient and provider as well differ significantly. Um, the patient may want one thing, and the provider may be like, no, we need to do this instead. So there are ethics committees that can help with those specific what's the word I'm looking for, dilemmas that may occur. They all of your hospitals, some even of your hospice, organizations will have some sort of an ethics committee to review, to make sure that we are providing the appropriate care, right, to our clients. All right. So let's see. A terminally ill patient on home hospice care gets short of breath with activity. What is the priority nursing intervention for this patient? So we have a terminally ill patient on hospice care. She gets short of breath when she has active. What can we do?
B.
B.
Right? Let's give her some oxygen, right? Um, it's not life-saving, right? It's a palliative treatment. It's comfort care. Give them some oxygen if they get short of breath, right? Help to make them as comfortable as possible. All right, so before we go into cultural, let's go ahead and take a break. Let's be back at 4:10. All right. So looking at cultural aspects, or cultural perspectives. Um, so cultural perspectives or their beliefs are going to affect um, how a person will approach death. And so part of, our responsibility as nurses is to assess each individual to determine their unique preferences and viewpoints so that we can provide that culturally sensitive care. Um, Perceptions of pain may differ as well. Um, in some cultures and religious traditions, it's a test of faith. Um, and so, even how pain is expressed, right, is different amongst cultures. Some are more open and vocal about their pain. Some people are more stoic when it comes to expressing their pain. And so assessing them and making sure that we are meeting all of their needs is extremely important. And that's why really, meeting with the family, um, meeting with the clients when they go into hospice care, and getting that information about what is important to them, so that we can incorporate that into their plan of care. And cultural too, when after they do pass, it's also respecting those wishes, when we're providing the post-mortem care, to our clients as well. So, I always ask if there is something that should be done or shouldn't be done, after somebody does pass. So, for example, I had a client, and I am not sure, honestly, I don't remember where they were from. I know they were Middle Eastern. They were not Muslim though. And when they had come into the facility for respite care, so we were just providing care. Um, I think the family didn't want the mom to pass at the home, so they brought her in for that, the last few days of her life. Um, and so when I asked the son, if there was any special considerations that we needed to take once his mom passed, the only thing that he said was to not shave any of her hair, which I was, okay. That took me by surprise because that wasn't, something that, we normally would think about doing. But the only thing that I can think of is, sometimes with older people, older women, they do have some hirsutism, right? So they may get a mustache or a little bit of a beard. And generally we will shave those, right? Because it's a dignity issue. But that was really the only thing that they recommended or that they told us was to not shave any part of her body. So obviously we were able to respect that wish. But always ask about their cultural preferences, spiritual considerations as well. We know that religious and spiritual beliefs play a big part in the lives of many of our older adults, even our younger adults. So we need to make sure that we are looking and determining whether there's any specific religious beliefs or practices that are important to either the patient or the family members. Um, Spiritual disconnection can occur, right? If they feel cut off from their source of spirituality or their religious community, right? They're not able to, attend church services or receive communion, whatever the choice is. Assess whether they have a preferred spiritual counselor, and whether they wish for a spiritual counselor to be notified. So for example, when my mom was passing, one thing that she did ask hospice was to have a priest come and give her last rites. We were born and raised Catholics. Um, and I don't know if they forgot, I don't know what happened. And so my mom passed on Mother's Day, of all days to pass. Um, I had gone grocery shopping that morning. My mom's favorite flowers were yellow roses. So I hadn't gone in to see my mom that morning. I got up literally and just went to the grocery store. And when I came home, I went to check on her to give her her roses. And my mom was not responsive. And she was still alive, but she wasn't responsive. And it dawned on me in that moment that, oh my gosh, this is probably the day that she is going to go. And I really, the priest had not come and given her her last rites. And I know that that was something that, she was very adamant about. Fortunately, after many phone calls, um, I was able to get our priest from our church to come, and give her last rites. And so I know that that was something that she really wanted to have done. So I was able to get that done. Um, so again, want to make sure that we're meeting their needs holistically, culturally, spiritually, physiologically, psychologically, to make sure that we make that as easy a process as for the client as well as for the family. Um, we look at depression, anxiety, and fear. Um, it's one thing to know that you're going to die eventually, right? It's another to realize that you've lived most of your life and that death is likely to be a reality soon. Um, and, everybody is going to approach death in different ways. And so individuals need to decide whether they'll give up, and let the fear and anxiety or depression overwhelm them, or whether they're willing to do something to remain in control of whatever time that they have left. Um, and so we can, help them through the stages by listening to their concerns, right? Helping them to deal with their concerns. We still want them to have some quality of life, right? We want them to participate in activities as much as possible, have interactions with their family members. Um, Anger is not uncommon, right? Especially right after that diagnosis is made or the terminal diagnosis is made. So again, allowing them to verbalize their frustration, their anger, um, and their, think of Eric Erickson, this is their integrity versus despair stage of their life, and trying to help them do this as much as possible. I don't know. Oops. Pain. What can I say about pain? Pain, oops, sorry. Pain is one of the biggest concerns that people have, and nobody wants to be in pain, right? And so, especially when the dying person is suffering from a painful disease like cancer, again, it's going to be one of the most significant concerns. Pain also, it can increase the likelihood of fatigue, depression, loss of appetite. Um, and it also interferes with the ability of the dying person to make thoughtful decisions, to communicate effectively. Um, and, it is pain at the end of life is a form of suffering, right? And so, one of the most important priorities when we are caring for a dying person is to provide for pain control. And so, assessing their pain often, using a variety of different techniques to relieve their pain is essential when we get to that end of life, especially if they are, have a disease that is going to cause them to be in significant pain. Journaling or keep journals, keep logs of pain. So, that we can make sure that it's being addressed and treated appropriately. One of the biggest medications that we use at end of life to treat pain, right, is morphine. Morphine is very effective for a variety of things, and pain being one of them. All right. So, question. So the provider orders morphine sulfate sublingually 0.25 mLs per hour as needed for pain. What teaching should the nurse provide about morphine? All right. So A, the patient should not request morphine until his pain level is at least an 8 out of 10 to avoid opioid addiction. B, the purpose of taking morphine for a hospice patient is to keep the patient as comfortable as possible. C, opioid pain medications can cause constipation, so a stool softener may be required. D, as long as the patient looks comfortable, the nurse will not disturb him to offer pain medication. Or E, the family should not get involved in assessing the patient's need for pain medication. All right, so which of those are correct? So should they wait till their pain is an 8 out of 10 to request pain medication? Absolutely not.
No.
Good job. The purpose of taking morphine for a hospice patient is to keep the patient as comfortable as possible. True or false? True. All right. Opioid pain medications can cause constipation, so a stool softener may be required.
True.
True. As long as the patient looks comfortable, the nurse will not disturb him to offer pain medication. It's a big one, huh?
Wouldn't that be false? Because you still would have to ask the patient how they feel. She's going by the look, right?
Right. And then the patient should not get involved in assessing the patient's need for pain medication.
Uh, True.
False.
Oh,
False.
That's
All
false.
right. So yes, the purpose of taking morphine for a hospice patient is to keep the patient as comfortable as possible. Opioid pain medications can cause constipation, so a stool softener may be required. Very good. Yes. So yes. Why don't we want them to wait till their pain is an 8 out of 10 to request pain medication?
because then you're chasing pain. You're not actually fixing the problem.
Yeah, you're chasing pain, right? So they're not going to get effective pain relief if we do it that way. Awesome. Fatigue and sleepiness. And so this is something that occurs when we look at end of life as well. It can be caused by the underlying disease process. Stress, anxiety can, of course, be caused by medications as well, right? Because especially if they're taking, morphine or Ativan, something along those lines, right? It can cause them to have some sleepiness that occur just because, those are central nervous system depressants, right? And we would expect that. Fatigue can interfere with their ability to carry out necessary end of life tasks, including communication with others, with their loved ones. Trying to think, sometimes we can, stimulants like, caffeine, prescription medications can help them overcome the fatigue, but, you want to be cautious with using those. You can teach them, about pacing activities, just balancing activities with rest periods. But then just because of the metabolic changes, they may begin to sleep more, right? And then as end of life nears, they may be more difficult to arrive, to awaken, arouse. Couldn't think of the word I was trying to say. With cardiovascular changes. So I think it was Joseph was talking about the modeling, especially around the knees and the ankles, but diminished peripheral circulation. If they already have it, it's likely to worsen as death nears. So they'll, get dry, pale, cyanotic extremities. Peripheral pulses are often weak and very difficult to palpate. Blood pressure is typically decreased. from normal. It also may be difficult to auscultate. A lot of times with our hospice patients, we don't do vital signs. Unless we, really need to. Body temperature may elevate significantly too as death nears. So they may develop a fever that is not related to an infection. So, want to make sure that they're comfortable, right? So making sure that we're adjusting the room temperature as needed. Whether they're hot, whether they're cold, making sure that they're comfortable. We talked about respiratory changes, right? And the death rattle or the Cheyne-Stokes breathing. Shortness of breath is very common as death nears. So those Cheyne-Stokes respirations, they also may have some other signs of respiratory difficulties that occur. So being, the Cheyne-Stokes are very recognizable once they do occur. But we do want to help them with their respiratory insufficiencies. So we can do changing positions, right? Elevating usually when we have a client, right, that has shortness of breath, right? We elevate the head of the elevate the head of the bed. That generally will help them to breathe a little bit better. Opening windows or using fans, that also helps. That increases the ventilation in the room. We can also give them oxygen via nasal cannula, and of course, provide education about the use of oxygen as well. Try to minimize as much stress around the child, around the client. So because we know stress, anxiety, right, is going to increase their respiratory rate, may even increase their shortness of breath. With GI changes, loss of appetite loss of appetite is very common. Muscle wasting as well, especially with advanced terminal conditions, and especially with some forms of cancer. It could, the xerostomia is the dry mouth. Ulcerations can occur as a result of dehydration, of medications, or even the disease process itself. They may have some nausea and vomiting. Constipation is also common, can be very stressful, distressful, or distressing problem for the terminal patient. That's why we had that question earlier, right, about giving the morphine. We may have to give a stool softener as well. If they're not eating and they're not drinking and we're giving them morphine, right, then that constipation can become a huge issue. Diarrhea is more or less common. Generally, it's constipation. But we know diarrhea can negatively affect their quality of life as well. With urinary changes, oliguria. So we talked about earlier with with the lady that hadn't produced any urine within, the 24 hours, but it's common generally because of the decrease in their fluid intake, their blood pressure, their kidney perfusion. Urinary incontinence is also common. So using pads or catheters may be helpful, right, to reduce the need for bed changes, especially, really at that end of life, trying to avoid moving them around as much as possible. We still want to turn and reposition, but, we want to try to keep them as undisturbed as possible. With skin changes, skin changes or skin breakdown is a problem with malnourished patients near the end of life. And there is a specific name for these types of injuries that occur with our end of life patients. And all of a sudden, I cannot think of what it is called. It's like on the tip of my tongue. It is a pressure area, but it has a specific name. And all of a sudden, I can't think of what the name is. But again, it is, skin breakdown is a problem. So keeping their skin clean, handling them carefully, frequent turning and repositioning, all of the other measures that we would use to reduce pressure on those areas, making sure that we're not shearing. I know my mom was famous for this even when she was younger, but she always used her heels to like push herself up in bed. So towards the end, she had like huge blisters on her heel just from shearing and pushing, using her heels to push herself up in bed, even though she had a hospital bed and she could use the controls to do all that, or just ask. Like I was there, my kids were there, my sister, um, but she, tried to remain as independent as possible until she couldn't. Soft, non-constricting, non-irritating clothing will also help to promote comfort, minimizes the risk for skin dryness and rashes, things like that. So again, just want to be really careful with their skin. Those nice loose nightgowns. In some cases, if they even the hospital gowns may be a little bit more beneficial. Sensory changes, vision diminishes, the visual field narrows as death does near. And so, in order to be seen, you need to be close to the patient. You making, indirect lighting, minimizing shadows, is going to be the least disturbing to them. Hearing remains active until death, even if the dying person isn't responding. So again, always making sure that you're talking to your clients, right, when you're going in to do things. Um, you want to calm, supportive, loving messages should be delivered. Any negative or disturbing constant conversation should be avoided to reduce stress and agitated in that dying person, right? We want them to be calm and, keep the environment calm for them. With cognition changes, delirium, which is a acute change in mental status, can affect the majority of our older adults in the final days of life. So they may have periods of, delirium and then periods of coherent thought. But common symptoms, with delirium is decreased ability to think and process information, disorientation. They may have like loss of consciousness, um, insomnia, daytime sleepiness, nightmares, agitation, irritability. And then, of course, your hallucinations, delusions, right? Memory disturbances can all be part of delirium. And many forms of delirium can be treated if we recognize them and report them. But some of the causes would be things like hypotension, oxygen deprivation, fever, neurologic changes, metabolic abnormalities, like your hyperglycemia, uremia, dehydration, or even emotional disturbances. Medications as well can contribute to delirium, like your opioids, right? If we're giving them that morphine for pain, that can contribute to delirium as well. Um, it can be very disturbing to the person that is dying. And so, as well as, the family members. So, trying to, provide the best care that we can. Education is always key. Try to find the cause of the delirium and see if there's any interventions that we can put into place to try to alleviate it. So comfort measures for patients nearing death, medications for pain or respiratory distress. So we use morphine. Morphine's a really, really great drug for a variety of reasons. So, for example, we talk about morphine for pain control, but it also suppresses the respiratory system, right? Because it's a central nervous system depressant. So patients that are have shortness of breath, maybe from COPD or even lung cancer or other other disorders and diseases. Morphine can be very effective not only for pain control, but also to relieve the anxiety from the shortness of breath, right? Because if I'm short of breath, what does that do? It's going to increase my anxiety, right? Because I can't breathe right. And when my anxiety level goes up, what happens to my respiratory rate? It goes up as well, right? So it ends up being a very vicious cycle. We give them the morphine suppresses that respiratory drive so they don't feel like they're short of breath anymore. Does that make sense? So it has a twofold effect. We can also give anti-anxiety medication, like Ativan is very common. Both of those can be given sublingual, so right underneath the tongue. So even if they have difficulty swallowing, right, it can get absorbed through the mucous membranes in the tongue under or in the mouth. Um, Medications for or light suction for oral secretions. So if they have a lot of oral secretions, a lot of drooling, a lot of gurgling, we can do some suction, or we can use something like atropine, which is an anticholinergic to help dry up those secretions to keep them more comfort. We can do oxygen, again, maintaining comfortable body temperature. So, there are Tylenol suppositories, right? If they do have an elevated temperature, I don't know if anybody's ever had a fever before, but fevers are very draining. They you just, it's just not a good feeling. And even though this is potential sign, um, for them that, they're nearing death, decreasing their body temperature can, provide some comfort for them. Um, and then of course making sure that they, if they're cold, they have their blankets, their socks, those kinds of things. Eye drops, oral care. Oral care is super important. It doesn't matter what stage of life that you are in, oral care is super important. Nobody likes a dry mouth. Nobody likes, we don't want the cracked lips, the cracked tongues. So making sure that we're good oral care. And we don't need to take vital signs. I mean, vital signs, as we get towards the end of life, they're going to be very difficult to obtain. It can also be uncomfortable for them. So we really don't need to look at taking vital signs. Um, family members are going to, may want to be present at the time of death. Some may only spend limited time with their dying loved one and wish to be called only when there's a significant change. Others want to be notified only after death has occurred. So you're going to come across a variety of different family dynamics, okay? For whatever reason, okay, those are your family dynamics. It just we'll just leave it at that. Family dynamics. The stages of grief. This is Kubler-Ross. So, the person, when we look at the loss of a loved one or even the diagnosis of a terminal illness, a lot of people will go through these stages. The first stage is denial. Okay. Like this isn't happening to me, the test results are wrong, or, they got me mixed up with somebody else. Um, could also be confusion, shock, fear. The next stage is anger. Okay. And so, this is frustration, irritation, anxiety. It's their way of dealing with helplessness and powerlessness. Um, it, they could, like be mad at their higher power, right? Why is God punishing me? And that kind of thing. It does tend to decrease a little bit over time. And then we go into the bargaining. This is, struggling to find meeting, right? This may be like, um, you know, if you let me live to see, my granddaughter get married, right? I promise to go to church every Sunday, right? We're bargaining. We're trying to get more time. Um, and then depression, that's the, feeling overwhelmed, helpless, alone, isolated. That's very common, whether it's for the person that has gotten the diagnosis or even the loved one that is surviving after the loss of a loved one. They may have frequent crying spells, they may have some insomnia, difficulty making decisions or concentrating, loss of appetite. Um, some people will try to hide their feelings, and just suffer internally. And then acceptance. So, acceptance, right? There's no set time limit for grief over the loss of a loved one, right? Everybody has to work through the process for themselves. You know, we do worry about, the extended grieving because that could have more negative effects on a person's well-being. But even the person that is, gets that terminal diagnosis, um, they are going to go through these stages. Eventually, they will get to the acceptance, right, where they, know that there's nothing else that they can do. And then after death, um, if family members are present, they should be allowed to sit sit at the bedside, say their goodbyes, say their farewells, grieve as long as they need. And then, you kind of want to remove all the lines, so remove the oxygen, IV, any other medical devices that may be present as discreetly as possible. You also want to accommodate and show respect for cultural practices regarding grieving as well as preparation of the body. Whenever whenever is possible, making sure that you're giving the family adequate time, providing them, with as much care as you can. You want to support the family. You also want to give them some privacy so that, they can have time with their loved one after they pass. And then your post-mortem care. And so again, you want to make sure that we're providing post-mortem care according to their cultural as well as their spiritual preferences. But typically you want to remove, sorry, any soiling, and put a clean sheet. Or shroud according to agency policies. But be mindful, and I can't remember exactly, and I think it is I think it's the Jewish population, and please forgive me if I'm incorrect with this, but you don't clean them at all. You leave them exactly as is because I think there is actually like I don't know if it's like a ritual in preparation of the body for burial. So you really don't provide any type of, real post-mortem care. You want to make sure they're closed, their eyes are closed. You want to put their dentures in their mouth, and I know that sounds a little strange, but put their dentures in their mouth. As when the funeral home is preparing the body, especially if they're going to have like a viewing, you want them to look as normal as possible. Can put a towel to, close the mouth, and then making sure that you return all of the personal belongings to the family. And then bereavement processes. Bereavement, like I said, this is, it's going to be different. How they express, their feelings regarding the death. They may feel relief, right, that the struggle is over, but they still miss their loved one. And even when, they know somebody is dying, the initial feeling of shock and numbness typically will still occur. Um, And so, again, some hospice, I'm going to stop sharing. Some hospice are really good at following up with the family after the death of a loved one. I will tell you, my mom's hospice nurse was great. I told you my mom passed on Mother's Day. And so rather than being home with her family and her children, she was with um my family. And so, I felt bad. I did tell her she could leave. But one thing that they did not do was follow up. They did not follow up after my mom passed. They didn't check to see, if there was anything that we needed. So, some are really good at it, some are not so great at it. I've heard different stories about different hospice organizations. But it is a service that most of them will offer. So, even if the family has to reach out to the hospice agency, for assistance, that is something, that is available to them. So I know today wasn't the happiest of lectures, but hospice care is really important. I've worked with hospice in the elderly population. I've also worked with pediatric hospice. And I will tell you, I'd much rather work with hospice with elderly population than with the pediatric population, only because kids are not supposed to die. And that was probably more upsetting than working with the older adults in the hospice setting. So, but with that being said, does anybody have any questions? No questions. All right, so next week is week 9. We have some more, and the exam reviews will start next week as well. So I will post those as soon as I have the list of the exam reviews. I will post those so you guys can go and attend the exam reviews for exam 3 in week 10. But I know not the most uplifting lecture today, but I hope everybody has a wonderful week, and I will see you all next Wednesday.
Thank you too. Bye.